relevant topic as childhood obesity is on the rise globally. Please welcome Dr. Bajpia online.
Uh, yeah, I hope my slides are visible.
Welcome, sir. Yes, sir, you are clearly visible and audible. Please continue.
Yeah. So we will start off with this very interesting case, which we are seeing very often now. The 16-year-old boy with obesity who presented to us with significant obesity, a weight of 127 kilograms, a whopping BMI of 46.7. He had a mildly elevated TSH, for which the pediatrician has said that, okay, this child has hypothyroidism causing this weight gain and started on thyroxine. Of course, this was the effect and not the cause of obesity. And 1 year later, he presented to us with frank diabetes, fatty liver. And this is not something which is uncommon. Obesity is something which is becoming increasingly common. If you look at the global prevalence in terms of obesity over a period of approximately 40, 50 years, there has been 20 to 30 fold increase in the burden of childhood obesity. And this has significant implications, not only from the short term, but also on the long term. And this is particularly common across the globe, not limited just to the developed countries, as
Dr.
was the
Anurag,
common.
Dr. Anurag,
Yeah,
because it
yeah.
is online presentation, can you make it a little less space so that the participants can understand? So
So you want me to go a bit slow?
a little slowly, little,
Okay, okay.
but
Sure, sure, sure.
loudly, no
Yeah.
problem.
Yeah. Okay. So there has been a clear-cut trend that there is a significant increase in terms of the prevalence of obesity across the world, approximately over a 20, 30 folds across the globe. And this is clearly seen across globe, not only on the resource countries which have got good resources, but also in developing countries, as highlighted by our study of around 5,000 school children in Kanpur, which showed a prevalence of 15% of obesity. There is a significant increase in obesity, which is a major cause of concern. And why are we worried about obesity? It's not just about acute complications. We are also looking at long-term morbidity. So there are significant implications in terms of long-term overall outcome, which may be affected in individuals who are overweight and obese. And this is a major cause of concern. Most adolescents who are obese by around 15 to 18 years will actually remain obese. So if we have to do something, we have to do in the pediatric and adolescent age group in that perspective. At the onset, I'd like to thank the organizers for this wonderful conference for inviting me, and I want to express my regret for inability to join for the physical session. Special thanks to Dr. Sherman, Dr. Yasmin, and Dr. Tanya, who invited me for this. And I'll try to focus about how childhood obesity can be the seed of a multiple of disorders which we don't even consider them, including disorders like cancer, kidney disease, and respiratory, bone mass, and so many implications from that perspective. All of you can go and have a look at our website, learning.society.in, which has got multiple resources related to pediatric endocrinology, including recorded video lectures, which are available. So when we talk about obesity in pediatrics, obesity could be physiological, which basically is because of exogenous constitutional calorie increase, which is essentially 98% of cases characterized by a normal growth, normal puberty, and normal development. While pathological obesity is rare in children, but it's usually can be because of really genetic causes, which in which they will have hyperphagia, vision abnormality, pubertal abnormality, and very early onset in that regards. There could also be some secondary causes, really hypothalamic or drug-induced. Particular drugs that we're talking about include the valproic acid, steroids, and anti-epileptics, which can cause that. They're associated with hyperphagia. While endocrine causes are rare, they are characteristically characterized by growth or pubertal delay. Just by looking at basic parameters, we can decide about which way we are heading to in that regards. So a physician encountering a child with obesity has to answer the question, is it really obesity? If it's obesity, is it physiological or pathological? And then what finally is the cause and the complications associated? So obesity, when we're talking about increased adiposity. Body mass index is a marker of overall body weight corrected for height. So we need to think of other parameters which are there, which can give you information, including waist circumference, which provides information about regional obesity, skin fold thickness, again about focal increase in terms of weight. The gold standards include the DEXA scan, which provides you the exact fat percentage, bioimpedance, or plethysmography, which are not clinically available. So which parameter should we use? And we did the study in the school children of around 5,000 children. What we found that if you want to look at the one single clinical correlate to the body fat, it's actually body mass index. So BMI, standard deviation score, remains the most important parameter to look at in terms of the overall growth and obesity in that perspective. Now, which charts to follow? What we really looked at when we compared the WHO chart with the local standard, that is the IAP criteria, we clearly found that the IAP criteria were better in identifying. So the use of international growth charts may underestimate the prevalence of obesity. So it's important to use local charts, stick to BMI, and that's how you will get the right picture from that regards. Now, once we know that this is obesity, the next question is it physiological or pathological? And the three things which will help you out differentiate a physiological cause from a pathological cause include growth. So there's a delay of growth, suggests endocrine causes. Delayed puberty suggests an endocrine or a syndromic causes, and delayed development will suggest again a syndromic cause. Other way to look at it, if you have a normal growth, normal development, normal puberty, don't worry too much about pathological causes. 98% are physiological from that perspective. So growth is extremely important. We expect the child who is coming to you in terms of obesity should be tall. If your child with obesity is short, think in that case of an endocrine pattern. So short and plump child is endocrine, short and tall is exogenous. The most important thing to look at in an obese child is actually the height, not the weight, and that will give you the clue in those cases. As was there in this case, this 12-year-old boy presented to us with obesity. He was reasonably tall. As far as the parents, the bone age was appropriate. The TSH was mildly elevated and he was advised treatment. This is a similar case I talked about one, and this is a very common presentation and referral. Now, if we really analyze the data, this is clearly a case who has a normal height. It is unlikely to be hypothyroidism, and in this case, we do not need to treat unless the TPO is positive. While we understand that subclinical hypothyroidism is the effect and not the cause of obesity, the subclinical hypothyroidism may also be doing some things. And in our study, what we found that individuals who had subclinical hypothyroidism had a higher predisposition to non-alcoholic steatohepatitis. And this is something which we need to follow up over time, whether there is a link between subclinical which predisposes them to liver disease in that perspective. However, at the moment, we do not recommend treatment unless the TSH is more than 10, there is TPO positivity, or there is a big goiter in that perspective. Now, once we know that this is a pathological obesity, we need to really go in terms of cause, start off with history to look at development, which will give us clues about specific syndromic disorders like Prader-Willi syndrome, brachymetacarpia in short stature and round faces with subcutaneous calcification will suggest pseudohypoparathyroidism. If there is a later onset obesity with a history of infantile hypotonia, small hands and feet, almond-shaped eye, think of Prader-Willi syndrome. Multiple fingers, visual abnormalities, polyuria, think of Bardet-Biedl syndrome. Visual anomalies, think of Bardet-Biedl or Alstrom syndrome. And delayed puberty, as said, part of multiple syndromes. So pointers of diagnosis will give you the clue. When should we think of genetic obesity? And this is something which we are thinking more. So the four cardinal rule are: is this happening soon, before 2 to 5 years of age, it's severe, is segregating, there's a family history which is present, or there are syndromic features like hyperphagia, developmental delay, vision or hearing defect. You should think of a clinical exome sequencing. So do not think of genetic causes in everybody. Only if there are clinical features like that should you worry about these parameters in that regards. So to summarize the approach to obesity in children: assess growth, puberty, and onset. If everything is normal, this is exogenous. Do not do much workup in terms of the cause. Look at complications. If growth is slow, think of an endocrine cause. While if it's a very early onset with developmental delay and dysmorphism, think about genetic causes, consider karyotype, Prader-Willi methylation study. If they are not contributing, think of a targeted panel for obesity. We have developed a mobile application, which is the Mediclass endocrinology application, in which we have an obesity interpreter, which based upon some key findings provides a very, very accurate diagnosis with a concordance rate of around 90%, which has been proven, and this is something which can help in terms of guidance of evaluation of obesity in that regards. Now, once we know the cause, which in most cases is not there, we have to worry mainly about complications. And this is what the main talk is about, that obesity is something that is going to affect each and every part of our body, including the next generation as well. There is an intergenerational effect. So one of the most important ones are dysglycemia. This is our study in which we found that a large proportion of individuals, approximately 55 to 60%, had metabolic complications at a young age. Many of them did not develop complications. This is something which we are working on in terms of metabolically healthy obesity. Now, whether this is related to genetics, gut microbiome, birth weight, environment is something unclear, but 40%, despite severe obesity, will not develop complications in that regards. So now we have a 12-year-old boy with obesity who is obese, has acanthosis, family history of diabetes. How do we work up? So what tests can we do for diabetes? The options include, of course, the fasting, the 2R, and the HbA1c. We know that the fasting has the highest specificity, and HbA1c is something which we can easily do because it's something, a single test, you don't need to do a fasting or a post-load sample. But there is a lot of confusion in terms of HbA1c cutoffs in children and adolescents. The RISE study, which really looked at in terms of how these parameters correlate over time, clearly showed that there was lack of concordance between HbA1c if you do it now and on follow-up within a 6-week period. So clearly HbA1c has got low reproducibility, and this is something which was reflected in our study as well. When we looked at the various parameters and correlation, we found that HbA1c was doing worst in that perspective. So if you're using HbA1c as a criteria for dysglycemia in children, use a higher cutoff, and some people suggest, including us, that we should use a cutoff of 6% rather than 5.7%, because 5.7 to 6% usually will have normal fasting, normal CGM, normal 2R value in that perspective. So HbA1c has a limited role in that regard. We have this child with obesity. He has pre-diabetes. There is mild elevation of fasting and 2R value. HbA1c is mildly elevated. What do we do in that perspective? So pre-diabetes in children is a clear-cut entity which can go both ways. This is our study of approximately 2-year follow-up, and what we see that many of them remit, but there is also a chance of progression. So this is something very important, and especially if somebody is not losing weight and there is a family history, there is a chance of progression. So a SGA child with a family history not losing weight, be very careful, will develop diabetes over time from that regards. 16-year-old boy with polyuria has all the features of diabetes, diagnosed with DKA on insulin with now reduced requirement. BMI is 27 kg per meter square, type 2 diabetes in family. Now this child was considered type 2 diabetes and insulin was stopped. Now this is something which is common but should be avoided, because obesity is happening more common in the population. We don't need to worry about, and don't think that every obese diabetes has type 2 diabetes. It's very essential to do a GAD antibody, and only if the GAD is negative, autoimmunity is negative, should we really consider this to be a case, and insulin should have ideally been continued. Now, diabetes in children is a progressive disease, very well established by the today's study, that there is a very rapid requirement of second agent compared to adults. They lose the beta cells much faster, 3 times faster as compared to adults. So we need to be very bothered, and this is something which we showed recently in our study, in which we found that a large proportion of youth with type 2 diabetes below 18 years require multiple drugs within 2 years of follow-up. So this is something to worry about. Best to avoid the development of diabetes in that perspective. Now, if we look at other complications, steatohepatitis is a major complication that we're looking at. And the key question is, how do we identify that? We can do liver function tests, but they are not really validated. The cutoffs are not clear. Ultrasound just picks up steatosis and not fibrosis in that regards. So what are the other options? We can't do biopsy in everybody. So transient elastography, and we have found this to be a good tool to identify. However, this is expensive. So what do? We did a study in which we wanted to correlate the SGPT or the ALT levels with fibrosis. And what we found is that there is a significant proportion of individuals who have latent fibrosis, and BMI is a major clue in that perspective. ALT levels above 52 suggested steatosis, and above 69 suggested fibrosis. So So if you're really bothered about, look at ALT levels. If they are above 69, that's a major cause of concern, because once NAFLD happens, it's a progressive disease. This is our data of over 100 children whom we followed up, and we found that most of them had persistent fatty liver and a weight loss of more than 10%. A BMI SBS loss of more than 10% was something which predicted improvement in that regard, and that was really, really important from that perspective. Beyond that, there are multiple effects on the heart. We find a significant proportion of hypertension in obese children, and this is something which we need to worry about. So we need to measure blood pressure in every child with obesity who comes to the clinic. There is an increased prevalence of sleep disordered breathing, and this is something which we know from adults has significant implications in terms of their outcome. Individuals who have sleep disordered breathing have a higher prevalence of steatohepatitis, which we need to worry about from that regards. Now, one thing which we are often not aware about is there is a significant link between obesity and cancer, and childhood obesity in particular provides a long-term exposure resulting in a significant cancer risk. So obesity is not just about short exposure, it's about multiple scenarios which are there from that perspective. There is also, so if you look at the other factor to look at in that perspective is that there is a chance of intergenerational effects. So if the mother is obese, there is a high chance of developing obesity in other perspective as well. So we need to be cautious from that regards. Now, having said all that, what can we do in that regard? So we have to break the cycle, start right from the mother, good maternal nutrition, treat and detect GDM, avoid stress. Primary prevention will include nutritional measures, lifestyle measures, and screening for complications. Once we have obesity which is developed, we should look at lifestyle measures and medications, try to prevent complications and screen from them. And if we really have, then we have to treat for hypertension, dysglycemia, and dyslipidemia. Our main bet is primordial prevention and primary prevention, because once we know that these things have happened, it's very difficult to treat. So what determines body fats, to be precise, and what we found interesting in our school study is, of course, this is something which is obvious. If a child is not sleeping enough and is not having significant physical activity, he will have a significant chance of developing obesity. So physical activity and sleep duration are the two most important determinants of body fat and obesity from that perspective. We have therefore developed a Fat to Fit app for children, which is going to be implemented in schools, which will look at their screen time, growth, sleep, and other parameters to identify. At the end, so we have tried to cover the entirety of obesity. This is something which is quite complicated and a lot of issues. So we'll keep that on discussion. All of you can go and have a look at our website, which provides a lot of information in terms of pediatric endocrine perspectives. And once again, thanks a lot for inviting me for this wonderful conference. Thank you.
Thank you, Dr. Bajpia.